Welcome to the CLDF podcast. I'm John Vierling, professor of medicine and surgery and chief of hepatology at the Baylor College of Medicine in Houston, Texas. And I'm broadcasting here from the 6th annual Liver Connect meeting in Chula Vista, a really marvelous venue with exciting and new information of interest to us all. I'm pleased to speak with you today about some newsworthy developments in the area of Wilson's disease, which most of you are familiar with as a disease, as an enigma. Now, you know and experience with your patients' populations undoubtedly that the diagnosis and treatment of Wilson's disease remains problematic for patients, their families, and for the variety of physicians that are called on to provide treatment. Wilson's disease diagnosis is often delayed, sometimes for years, because the multiple manifestations and presentations biochemically and symptomatically and signs and symptoms of particularly neurologic diseases can be misattributed to many other mimicking diseases that are far more common than this rare genetic cause of their malady. Wilson's disease has been treated sporadically by physicians of different types, from general practitioners to gastroenterologists to hepatologists to neurologists to psychiatrists, hematologists. And we know that the patients that are treated by physicians who have encountered up to 5 cases in their careers, in other words, experienced clinicians in the United States, when surveyed in 2024, showed us some striking findings. Namely, only about 40% followed practice guidelines from the American Association for the Study of Liver Disease for the diagnosis and management. Secondly, the vast majority chose for therapy D-penicillamine, the most potent of the chelating agents, and not the recommended trientine. And third, they changed therapies intermittently over relatively short courses of treatment among their patients. Now, we know that a European cohort of 62 physicians that were largely academic medical center-based physicians, this published Rare Diseases Network in Europe actually followed guidelines, used fairly consistently Leipzig criteria for the diagnosis of the disease, and more uniformly prescribed trientine as initial therapy for their patients. Now, Wilson's disease patients, when diagnosed and under treatment, have a poor quality of life, as do their family members in the household. They are dissatisfied usually with the disconnect between our telling them that there is evidence biochemically of improvement while on decopperizing therapies, while they themselves continue to experience signs and symptoms that they wish to be cured. Now, in 2026, the cumulative progress in basic science, translational science, and clinical research in genetics, in the utilization of drugs, in the development of new drugs, and importantly, in development of assays for copper in serum, have raised the possibility of a new era of more sound diagnosis made earlier in the course of a patient's disease and with better potential outcomes, and most importantly, knowledge-based and evidence-based outcomes for copper removal from the body stores of all patients being treated. So today I'd like to highlight a couple of things regarding this new knowledge that I think will be of interest and certainly can be applied, I hope, in the future as these developments reach fruition in clinical practice. First issue is genetics. Genetics have continued to identify risk alleles within the gene ATP7B, which encodes an ATPase copper-specific transporter that moves copper from hepatocytes across the apical membrane for excretion in bile. where it is no longer absorbable from the gut and passes out in the feces. And in normal people, that accounts for about 86 to 90% of all copper excretion from the body on a daily basis. These genetic abnormalities of single nucleotide polymorphisms within this gene occur in 21 different exons. The most frequent exon showing abnormalities is exon 8, but many others are involved. And in fact, about 85 to 90% of newly diagnosed Wilson disease patients who have genetic testing have a heterozygosity in one allele from the father and another allele from the mother. And so they have a compound heterozygosity. They don't have homozygosity between alleles. And the absence of homozygosity as a fundamental bellwether for diagnosis has really hindered our ability to diagnose this disease. And we are now up to 9,700 different variants that have been identified. Over 900 now have proven to be pathogenic. And there's a number of other variants of interest, which with time may also prove to be pathogenic. Now, as this research includes now the new generation sequencing, we know that additional factors, such as epigenetics that regulate gene expression, are in play also in Wilson disease. And this kind of cumulative knowledge leads to the prospect that we will be able to use technology already developed, namely a dried single blood spot that can be analyzed for particular alleles of interest that dictate the diagnosis of a genetic disease in neonates for future screening. But this is going to require that we have the complete inventory of all the risk alleles that are pathogenic. But that's an exciting prospect when you look at a worldwide future event with screening for neonates for a rare disease like Wilson disease. Now, when we look at the frequency of all these new gene studies, we're struck by the fact that all of our prior estimates are wrong. We once thought that the carriage rate of a single person with one allelic variant was about 1 in 250 in the population. We now, from newer information, know it's 1 in 90. We once thought that the gene abnormality of 2 heterozygous mutations, compound heterozygosity, would be present in about 3 per 100,000. We now know in the UK it's present in 1 out of every 7,026 people, with a 95% confidence interval up to 1 in 20,000 people. Quite a different estimate entirely. So, in other words, there are many more patients with the genetics of Wilson's disease than there are patients that we have diagnosed with the disease. And this gets us to this issue of delay in diagnosis, misattribution of signs and symptoms to other diseases that can mimic or have conflicting laboratory values for patients with Wilson's disease. It makes us more mindful that there are many more cases probably to be diagnosed, and we should be cognizant of that fact. Now, how would we diagnose patients? I mentioned earlier that this recent survey from Europe found that the academic physician centers were applying the diagnostic criteria referred to as the Leipzig criteria, developed by a panel of experts in 2001. These criteria have merit because they systematically force you to identify values for every one of the parameters and to assign a score, which is tallied up to show that the patient has highly probable disease or certain disease, probable disease, or unlikely to have disease. So what does it entail? It entails clinical symptoms and signs, Kaiser-Fleischer rings, copper deposition in the descent membrane of the cornea, neurologic signs and symptoms compatible with Wilson disease, and hemolytic anemia, non-Coombs positive in type. It also includes measurements of serum ceruloplasmin and 24-hour urinary copper excretion in a 24-hour urine sample. It also includes quantitative hepatic copper and staining of an hepatic biopsy specimen with rhodamine, either present as positive staining or absent. And it includes mutational analysis using, as I said, more sophisticated databases, which will allow us to detect these numerous pathogenic loci. When you use those criteria, you have a strong chance to make the diagnosis. And in those cases that are unlikely, to search for an alternative diagnosis. And for those that are possible but not definite, to search further to see if there are other comorbidities or something being missed. Now, when we move into the next information being generated, we have to focus on, again, our testing for copper, ceruloplasmin, and non-ceruloplasmin copper. So as a background for that, you're all aware that in normal people, copper uptake from the gut is into hepatocytes. Hepatocytes then cause a component of copper to pathway into population of apoceruloplasmin, which matures into ceruloplasmin, excreted into the blood. The other residual copper is the subject of this ATPase transporter encoded by the ATP7B gene, and hence they have the biliary excretion of copper of a normal person. We know that in a Wilson patient, the ceruloplasmin synthesis from apoceruloplasmin to ceruloplasmin and its secretion is defective because of the gene defect in the transport to bile, and as a consequence, the amount of ceruloplasmin tends to be low in the serum, leading to an overall low total copper in the serum. And that total copper is about 95% composed of ceruloplasmin. So a low ceruloplasmin will give you the majority of the reason to have a low serum copper, and the remaining is non-ceruloplasmin copper. Now, non-ceruloplasmin copper has been with us for a while, and in fact, we have had parameters in our guidance for treatment saying that you have specific goals to treat a patient and decopperize them until the non-ceruloplasmin copper level has fallen into the normal range of 40 to 150 micromoles per liter. And that dictation would be all well and good, except for the fact that the calculation is based on erroneous information. That being that every molecule of ceruloplasmin always has 6 molecules of copper covalently bound within it. That isn't true. And because it's not true, the calculation based on that assumption can lead to wacky numbers, including negative numbers that make no biologic sense. So we've been in desperate need for a better test for accurate detection of non-ceruloplasmin copper. And we now have them. And they are moving toward clinical use. The first and most interesting, I believe, is the speciated protein, which uses a mass spec technology to accurately define the non-ceruloplasmin bound copper. That particular test has been studied in several different ways and proven its ability to help in the diagnosis of such things as acute liver failure caused by Wilson disease, where that accurate, speciated protein, NCC, and the addition of ALT into equations had an AROC curve of 99.99 for accuracy as the etiology of Wilson disease for that acute liver failure. It's also been studied in patients who have been chronic treated and are on maintenance therapy with depenicillamine and depenicillamine patients in that same state who were randomly then switched to receive tetrahydrochloride trientine. And in those particular studies, when they then looked at the maintenance and are they adequately decopperized, they found to their surprise that with this new measurement, you had lower than expected levels of non-ceruloplasmin copper, while you still had persistence within the population of abnormalities of 24-hour urinary excretion of copper, which of course is problematic for patients to collect an entirely accurate 24-hour specimen and to therefore have confidence in that measurement. So one of the take-homes from this is that in the near future, I predict that we will not be using the way we once did, 24-hour urinary copper in the management of our patients on therapy, seeking to understand whether they are adequately decopperized. We're going to be switching our strategy to look at non-ceruloplasmin copper. And what we're going to need to do is we're going to need to reassess what are the parameters, what are the values that indicate actual decopperization of individual patients. They're likely going to be lower than we thought they once were based on this erroneous non-ceruloplasmin copper calculation that we've used for decades. Now, another way of looking at non-ceruloplasmin copper is to look at the exchangeable amount, the labile amount that can be extracted by chelation from the specimen. And when you do that, you should anticipate that all that is not bound to ceruloplasmin, in theory, would be extractable. It's not actually true. If you compare the extractable NCC with the speciated protein NCC, they correlate, but they're not identical. In fact, they have sort of a systematic difference between the two. This extractable or exchangeable amount is important, I think, in terms of our understanding, because it, in theory, is the amount that is subject to uptake by other tissues in the body. So it's that exchangeable amount that can keep populating the copper stores and replenishing them as Wilson disease progresses in an individual before treatment. And one has an additional use for that test, and that is the relative exchangeable test, which is the ratio between the exchangeable NCC divided by total serum copper. Now, normal people have a normal range of about 4 to 8%. Very rarely, it is about 10%. Wilson patients in the largest single study looking at this particular value conducted in France had an optimal cutoff at 14% for diagnosis. And that was 96% sensitive and 99% specific. So a highly accurate result. Others have argued that if you set it higher and call the cutoff at 18%, that you will be virtually 100% sensitive and specific. And there's going to be debate until further studies clarify that situation. But you can see the potential value there. And that the value, I think, can be utilized in future designs of algorithms for testing, such as potential addition to things like the Leipzig criteria that we discussed before. The next issue for us that's newsworthy is an update on where we stand with new therapeutics. And to look at that, we have to first look at older therapeutics and what has been added to them and what will be coming with new drug development. When we look at the older therapeutics, you're all aware of the story of depenicillamine, which was a life-saving therapy, but prone to many adverse effects, some of which could actually be lethal. And we have that was supplanted by trientine. The trientine was a dihydrochloride molecule, More recently, there has been FDA and EMA approval of a tetrahydrochloride trientine. This has a non-inferiority to trientine dihydrochloride, but it has one advantage. There's a significant one in that it is not heat labile. Hence, you do not need to refrigerate it. And in fact, in studies that have compared the two, one found that many of the issues that led to discontinuation or missed doses of the trientine dihydrochloride were due to the issues of refrigeration, transport, or having something go wrong in getting it from transport to refrigeration and interrupting the treatment cycle. We know that in addition to that, there's going to be enrolling shortly a once daily study of the trientine tetrahydrochloride, which would be obviously a breakthrough if we can have effective decopperization and chelation on a once daily basis. We also have zinc, which works not as a chelator, but it causes production of metallothionein in intestinal epithelial cells, which then bind copper, don't allow it to transport into portal venous blood, and end up shedding the copper, dietary copper, in the stools. We then have sort of newer compounds. The first would be a potent chelator, and this was the tetrathiomolybdate. Tetrathiomolybdate has a very potent ability to chelate copper and was thought to promote the excretion of the chelated complex into bile. However, studies recently published in normal volunteers as well as small numbers of patients with Wilson disease failed to identify copper excretion in bile after the administration of radioactive copper-64, allowing the tracer to be followed into the gallbladder from the liver. So there is the ability to chelate. It will lock in the chelated product within the bloodstream, and through the chelation prevent the entry of excess copper into the hepatocyte, but not to allow it for biliary excretion. And because of that, in the chelation being very potent when it's taken orally, one has the chelation also in the gut, so it acts to prevent absorption. So where we stand with that is sort of at a crossroads of understanding mechanism of action, safety, and the way in which you would determine effectiveness of this compound. Then we come to a very important development, and that is methanobactin. This is a bacterial-derived chelator, very potent in terms of its binding efficacy, and has been studied and published in rat models and in intestinal epithelial cell models in rodents and in the epithelial cell models in humans. In the rat Wilson disease model, it has an outstanding capacity to chelate and remove hepatic copper into the bile so that it depletes the hepatic copper overload over a course of approximately 8 days. This is actually a phenomenal achievement because even well-treated patients with chelators like depenicillamine or trientine do not have substantial reductions in the overload of hepatocyte copper. This drug has that capacity and could then obviously move copper into hepatocytes for further excretion, draining the stores of copper in equilibrium with the blood, such as those in the brain and the cornea, the kidney, and other organs. So it's an exciting development, which we hope to see in appropriately designed clinical trials. Next on the list of nuanced information is this important issue of sort of the liver and brain axis. And I think that's the important axis because the liver is the site of the impact for this gene disruption. and the quantity of copper that is going to spill over into the circulation and be distributed through the exchangeable copper pools into these peripheral sites, such as the central nervous system. And we know that there is and has been taught to us a paradoxical possibility that with neurologic Wilson disease, we can worsen the patient's condition, signs, and symptoms when we begin chelator therapy. That usually is within the first 6 months. And the thought has been that the chelation, by being potent, allows for a buildup of exchangeable copper, and that buildup of exchangeable copper leaching out of tissues and moving its way toward further chelation and excretion in urine is in free exchange with the central nervous system and may actually increase the entry of copper into already toxic cell environments and worsen the symptoms. And this has led to the concept that one wants to go sort of low in dose and slow in increasing doses in patients specifically with neurologic disease, and in particular, if there is imaging evidence of brainstem or thalamic involvement with copper overload. Those are the two sites that are most at risk for this worsening. Paradoxically, there is also a late worsening that can occur in neurologic symptoms of patients with Wilson's disease. And this is poorly understood and is theorized in a variety of explanations that lack a fundamental basis for understanding, but are worthwhile knowing about. And I think translate best in terms of what we're going to see as clinicians to the concept that I call myself the walking wounded, which are the patients with neurologic symptoms on maintenance therapy who persistently have a degree of neurologic dysfunction. Those particular patients are very problematic to me because you wonder if they had true decopperization, would they have less symptoms? You can't prove it without knowing what true decopperization is, which is, I think, where we're going to have an advantage with these new assays of the speciated protein NCC, and can really pin down when an individual patient is fully decopperized. But it is sort of the holy grail. And we know it's probable. And the reason we know it's probable is that there are a number of reports and series of patients in that condition who have a liver transplant. The liver transplant rectifies the entire metabolic profile, and now with the ongoing biliary excretion, their neurologic symptoms can improve over a course of 1 to 5 years, and in some reports even improve out past 8 years. So it suggests that there still is room for decopperization to improve these patients and no longer make them the subject of the walking wounded. So lastly on the list is the Holy Grail. Can you replace the defective gene? And this is being studied right now in clinical trials with Ultragenyx that has a adenoviral vector targeting hepatocytes with a truncated gene that has the full operational capacity of the entire ATP 7B gene, and those trials are underway. Another trial that was being conducted was discontinued, and that trial also used an adenoviral vector to replace the gene. And we hope that further trials in this area are going to be able to be helpful. And the one that stands out to conclude with is one coming from Prime Medicine, in which they're going to insert a regulator so that they can attack one of the key allelic heterozygote mutations, the H1069Q mutation, which is overrepresented in European populations, with the idea that those that are positive for that mutation be the study subjects to see whether changing that single gene, that single nucleotide polymorphism, can be beneficial. So much has been done. There's much more to be done. I hope you share the excitement that I have that we may be at a crossroads. Thank you for listening. Please subscribe. And for more content like this, please visit the CLDF website at chronicliverdisease.org.